Hello and welcome. Thank you for joining us. We're going to give people a few more moments to come in from the waiting room, and then we will get started on today's CME. Okay, I see the participants list is still growing, but for the sake of time, I think we'll move along with the beginning of our CME. So first, thank you for joining this Concussion Legacy Foundation continuing education event. It's in partnership with Boston University School of Medicine. My name is Michael Burke. I'm Associate Director of Patient Programs at Concussion Legacy Foundation, and I am thrilled to be bringing two excellent speakers for this event, Dr. Jesse Mez and Dr. Mike Alosco, who I will be introducing in just a moment. We will also be giving some information about disclosures and instructions for how to claim your free credits for this event. With that, I'd like to introduce today's speakers. First is Dr. Jesse Mez. He is an associate professor of neurology at Boston University School of Medicine, director of the Boston University Alzheimer's Disease Research Center Clinical Core, an investigator in the BU CT Center, and co-leader of the Framingham Heart Study Brain Aging Program Clinical Core. His research seeks to understand genetic, neuropathological, epidemiological, and clinical aspects of Alzheimer's disease, CTE, and related dementias. He received his AB from Cornell University in mathematics, his MD from the University of Maryland School of Medicine, and his MS in biostatistics with an emphasis on statistical genetics from the Columbia University Mailman School of Public Health. He completed his neurology residency at Harvard Partners Program in Boston. This was followed by a clinical fellowship in aging and dementia and a research fellowship in neuroepidemiology at Columbia University College of Physicians and Surgeons. Thank you for being with us, Dr. Mez. Dr. Mike Alosco is an associate professor of neurology at the Boston University School of Medicine, director of the Boston University Alzheimer's Disease Research Center Clinical Core, and the director of neuropsychology at the Boston Medical Center Memory and Aging Clinic. Dr. Alosco is a licensed clinical neuropsychologist. He completed his undergraduate studies at Providence College, and he earned his doctoral degree in clinical psychology with a focus on neuropsychology in 2015 from Kent State University. Dr. Alosco completed his postdoctoral studies in neuropsychology via NIH-funded training awards at the Boston University Alzheimer's Disease Research Center and CTE Center. Next up, we just want to make a note about disclosures. Some of the work covered today has been supported by NIH. There are no other relevant disclosures to report. And for instructions to receive your free credit, please look for instructions in the chat and in a follow-up email that Concussion Legacy Foundation will be sending out. As a reminder, this is brought to you by joint providership with Boston University Chobanian and Advesian School of Medicine. It is eligible for one AMA PRA Category 1 credit and one APA CEP credit. So with that, I will hand it over to Dr. Alosco and Dr. Mez to bring you today's content.
Thanks, Michael. Hello, everyone. Just give me 1 second. Hi, everyone. So I'm really excited to be here with Dr. Mez to talk to you a little bit about our research and our experiences that relate to the clinical assessment and care of people concerned for chronic traumatic encephalopathy or CTE. So the goal of today is twofold. So I'm going to start off actually by talking more about the research with a clinical orientation about about the use of neuropsychology and the use of biomarkers for neurodegenerative diseases in general, but with emphasis on CTE, of course. Well, through this review, I'll touch on some of the updates we have on the diagnostics on CTE and where we stand. And then I'll turn it over to Dr. Mez, who's really going to go through everything you need to know about a memory and aging clinic visit using our clinic as an example. And I'll let him talk more about that, but that experience, we've had that clinic for 3 years now, and it's really shed some important kind of both empirical and anecdotal kind of insights into the presentation of this disease. So let's just start off with a brief review of what it is we're trying to detect and trying to study in living individuals and participants and patients. So this disease, chronic traumatic encephalopathy, or CTE, it's a neurodegenerative disease, unlike any other neurodegenerative disease, and it's characterized by a unique lesion of hyperphosphorylated tau. It's unique because it gathers around small blood vessels. So here on the right, you see the brown, which is the tau of CTE, and it tends to gather around blood vessels, which is this white circle here. And it also tends to gather at the folds of the brain. And this is something that's very different, like I mentioned, different from Alzheimer's disease, different from any other tauopathies. Here, there's 4 stages of CTE, 4 stages of severity. So stage 1 is the least severe, and really this is kind of one or two isolated lesions of p-tau, typically beginning in the front part of the brain or the frontal cortex. Stage 2, the lesions start to spread to other adjacent cortices, including the temporal and parietal lobes. And then stage 3 is really when we get kind of more of a dense accumulation of the pathology, and it starts to hit the medial temporal lobes or middle parts of the brain. And then stage 4, it becomes widespread. As you see here, we see pretty robust correlations with both age and dementia status as the disease progresses through the 4 stages. The primary risk factor for chronic traumatic encephalopathy is exposure to repetitive head impacts, or RHI. So this is work that Dr. Mez has led at our center, where he's investigated risk for CTE. This study in particular here looked at American football players from our brain bank and found that a dose-response relationship between the number of years played and risk for CTE. So here on the left, or in letter A, among the sample of people with and without CTE, the odds for CTE increased by 30% for each year played. And then for each 2.6 years played, the odds of developing CTE doubled. And we find a similar relationship with CTE severity. That is, there's a dose-response relationship between the years played and the severity of the disease in the brain. And in addition to this study, there's been many other studies that have continued to link various proxies of exposure to repetitive head impacts and risk for CTE or other types of neurological outcomes. The problem we have right now, we cannot yet accurately diagnose this disease during life. We have a good understanding of what this disease looks like in the brain through the brain bank at the BU CT Center, which is the largest of its kind in the world. And we have a good idea of what the risk factor is for CT, that is repetitive head impacts. Now it's time to kind of really figure out how can we accurately detect CT in living individuals so that we can study risk factors. Why do some people develop the disease and some people don't? And we can start to also investigate treatment and prevention strategies. We have made quite a bit of progress on this over the years, and perhaps most reflected by the development and publication of the 2021 TES research diagnostic criteria. So this gets a little confusing now with all the acronyms, but TES is traumatic encephalopathy syndrome. It's meant to reflect the clinical syndrome of CTE. And so this was developed through a consensus conference across over 20 different scientists, across many different institutions, across many different disciplines. And these criteria, I'll summarize them briefly here. They're quite nuanced, but in a nutshell, they require substantial exposure to repetitive head impacts. And a lot of what how we operationalize this is based on what we've seen in football and the years of play study I just described. They require the presence of two core clinical features. This is cognitive impairment, specifically in memory or executive function. They also require what we refer to as neurobehavioral dysregulation. So this is a term referred to trouble with managing emotions, kind of aggressive behaviors, explosive, getting angry over trivial matters, impulsivity. Now, these criteria are still research-based. They're not for use in the clinic. We don't yet know how they work. There was a 2014 iteration of them that proved to be sensitive but not specific, and we think we did a pretty good job of improving the specificity of these criteria, but we're still formally studying them, and so we don't yet apply them in the clinic. And another reason why we don't yet apply them is because a lot of these criteria, these symptoms here, they were based off of research in our brain bank. The brain bank is an amazing resource for studying the disease in the brain, but we do collect a lot of our clinical data by talking to informants, so it doesn't have prospective, objective evaluations of symptoms. And so that's something we need to do in order to really kind of nail down the clinical presentation of CTE, and which is also my kind of third point. And in particular, kind of one of the cornerstones to diagnosing and evaluating these neurodegenerative diseases like Alzheimer's disease and now CTE is neuropsychological evaluations. And that's data that we've been lacking, although, as I'm going to review, we have made strides towards acquiring this data. So for the rest of the presentation, what I'm really going to focus on is the role that neuropsychology plays and will play in the diagnosing of CTE in living individuals, and also how the field has now changed to kind of pairing our neuropsychological assessments with biomarker data to kind of give us the best chance of getting the diagnosis right. So what is a neuropsychologist? So I like to borrow from this quote. I'll read the first couple of sentences here and then let you read the rest of it. But a clinical neuropsychologist is a professional within the field of psychology with special expertise in the applied science of brain-behavior relationships. Clinical neuropsychologists use this knowledge in the assessment, diagnosis, treatment, and/or rehabilitation of patients across the lifespan with neurological, medical, neurodevelopmental, and psychiatric conditions, as well as other cognitive and learning disorders. So it's our job as neuropsychologists to evaluate the function of the brain, help with diagnosis, and help with treatment recommendations. So these are the four kind of objectives or roles that I like to think of neuropsychology. So one, as we get older, everyone tends to have decline in their memory. It's part of natural aging. What us as neuropsychologists are trying to answer are there impairments in memory that are abnormal for aging? Does this 65-year-old have more problems with memory than I would expect for that 65-year-old? So we can identify the presence of cognitive impairment. And then we can also identify how severe that cognitive impairment is. Now, not all places or centers are fortunate enough to monitor for cognitive decline. That is, as neuropsychologists, particularly out in the community, we often see a person one time, and that's just a quick snapshot. But really, the value of neuropsychology comes in when you can look at people across time. And so once we can do that, then you can start to monitor for cognitive decline and get a true idea, is this a progressive brain disease? We can also help to inform on etiology. If there is cognitive impairment, what might be causing that cognitive impairment? And then finally, we play a big role in educating. This is particularly valuable in CTE, where there's a lot of information out there, some of it accurate, some of it not accurate. And we play a big role in kind of what do we know about CT, what do we not know about CT at this time. So some people might be more used to kind of cognitive screening. And so I think it's really important for those non-neuropsychologists out there to kind of differentiate what do we mean by cognitive screening versus a neuropsychological evaluation. So cognitive screening, someone has concerns, they might go to their PCP, they say, I have memory problems. That PCP or other provider might do a brief cognitive screening, appropriately so. However, it shouldn't end there, right? So that cognitive screening can identify concerns and can guide referral, but there's also a lot of false positives. It can over-identify impairment. There's a lot of false negatives. And it doesn't have specificity. It won't help to inform etiology. And so some of these screening measures you might be familiar with, like the MMSE or the Montreal Cognitive Assessment. Again, they're really great at giving a brief kind of quick window into that person's global cognition and for monitoring change over time. And it doesn't require neuropsychologists, right? Most people can do this. But it should not replace a neuropsychological evaluation. And so a comprehensive neuropsychological evaluation, these can really range in time depending on the provider and depending on the kind of referral question. But if we're thinking about a typical dementia evaluation, you really try to keep them somewhat brief because of the population you're dealing with, but you try to hit on all the different domains of thinking. So we need to kind of estimate their pre-morbid intelligence. What was this person functioning like before disease? And then we cover all the domains. We look at their attention abilities, their executive functions, their language, their visual spatial abilities, their memory, their learning, and so on. Effort, again, it kind of varies by provider about assessing effort. We do assess effort in all of our patients. There's some settings where it might not be indicated. Other settings you should definitely assess, like more of a forensic setting. But we do assess effort for all of our patients. So here's an example. Ultimately, what we're trying to do with these neuropsychological tests is assess, is the brain functioning like it's supposed to, right? So in the neuropsychological evaluation, we sit someone down in a quiet room and we test different domains of thinking. Now, we understand that the quiet room isn't kind of the natural environment, but at the same time, it allows us to say, okay, when this person doesn't have distractions, this part of the brain is or is not functioning like it's supposed to. And here's an example. When we look at things like memory, we're tapping into like the hippocampus, for example, when we're looking at kind of storage and memory. And so these kind of gives really good idea of brain function. After a person completes the neuropsychological testing, the work kind of starts on our end. We score all tests according to kind of standardized protocols, and we generate what's called raw scores. Then we take those raw scores and we convert them to standardized scores. Now, we convert to standardized scores using data of people who don't have memory problems, who are similar in age, sex, and education. There's various types of norming practices. There's a lot of different norms out there. But in general, the goal is to select the norms that are most appropriate for the person in front of you. And at the end of the day, as Dr. Mez will talk about, a diagnosis and our treatment never relies just on one data point. So our judgment is always involved here, and it kind of goes beyond our norms. Because we all also know that our norms aren't great as well. It's a problem in the field. Our norms are based on people who are white from European ancestry. They lack cultural sensitivity. They're often based on small sample sizes. But either way, so we get those norms, and then we can identify impairment, right? We can say this person has more problems with memory compared to a 65-year-old with the same education. And we can specify what are the domains most affected and how may this impact that person's daily function. And then we combine our performance, we combine it with our history, and we come up with the differential diagnosis. And the first part that we contribute to is the clinical syndrome. We use the neuropsychological profile to help with diagnosis of the clinical syndrome. So in the Alzheimer's disease and neurodegenerative disease world, we typically think of the syndrome in kind of three bins. right? So you can have cognitively normal. This is often can be also the preclinical state. So this is people who have no problems with thinking and memory, not impaired on testing, but there might be some evidence of pathology in the brain. Now, again, whether or not they go on to develop impairment is a different story, but that's kind of that bin. Then there's the mild cognitive impairment, or MCI bin. And this is typically those people who have concerns, they have memory concerns, and they are impaired on neuropsychological testing, but they're still functioning okay. So they're still paying their bills, they're still driving, they're doing all the things that they need to do on a daily basis. And then there's dementia. The dementia is there's concerns, there's impairment on neuropsychological testing, and now that individual is having trouble functioning. They can no longer drive, perhaps, or they're getting lost while driving, they're forgetting to pay their bills, they're leaving the stove on. They require assistance with activities of daily living. So each of these bins really hinges upon the outcomes of the neuropsychological test data. And the course, we have a down course here, and that's kind of the expected trajectory of a progressive brain disease, but that arrow can really be at all different angles and slopes. Some people can stay in MCI and not progress or stay there for quite a long time. But the most common question we get is, okay, so what's going to happen to me next year or 5 years? And it's the toughest question we have to answer, because even in Alzheimer's disease, it's really hard to answer that question at the individual level. And in CT, we really can't answer that question because we have no great longitudinal data. So once we kind of nail down the syndrome where that person is on that trajectory, we can also use the neuropsychological data to inform on etiology. Now, this is a little bit outdated, but it kind of drives my point home in that the different diseases, different disorders, conditions, they can produce different patterns on testing. So, for example, in Alzheimer's disease, we really look for a pattern of episodic memory impairment, rapid forgetfulness, trouble with confrontation naming, and those are the domains we really kind of hone in on, among others. Now, it becomes a lot trickier, and this is going to get us into the use of biomarkers, but we also now know that Alzheimer's disease and all these neurodegenerative diseases have atypical presentations, so that kind of throws us a little bit of a curveball. We have been investigating the neuropsychological profile, so including rates of impairments, including patterns in people at risk for CT. So we've used the Diagnose CT research project, and you can ignore that photo caption there. This is from the Diagnose CT project. But this is a study studying people at high risk for CT. So it includes 120 former National Football League players, 60 former college players. Then it included a group of people of same age men without symptoms and no exposure. So this is actually ending in this fall, but the baselines have been completed. The 3-year follow-up had to be pivoted to remote because of COVID-19, so that's a little bit inaccurate and outdated now. But for the purposes of this talk, they completed a comprehensive battery of neuropsychological tests that we recently published on. And so here's the battery we gave. You can see it is quite extensive. It's about, I would say, 1.5 to 2 hour battery. And we, again, touched on every domain, including effort, performance, validity. We looked at learning and memory, both verbal and visual. It looks like some of the tests and domains got oh, no, that's right. Yeah. And then we looked at executive functions, several tests per executive functions, attention, language, and visuospatial abilities. So the sample we studied here was the Diagnose sample. Now, we did exclude participants for missing data, and notably, we also excluded participants who did fail effort testing, just because we weren't as confident in those scores. And so it left us with 170 football players. 111 of them were professional, 59 were college. They were around 58 years old on average, the football players. About 32% were Black. We did not include the control group in this sample simply because the recruitment strategy of the study was based on symptoms, And therefore, if any difference we found, we thought might be due to our recruitment strategy, as opposed to kind of actual differences on neuropsychological testing. What we found was the highest rates of impairments were in episodic memory. So we defined impairment by people who had 2 or more tests in a domain with a standardized score of 1.5 standard deviations below the mean. And there we found episodic memory to be the highest rates of impairment, including almost 45% being impaired on long delay of words. This is a particularly sensitive measure that we look at quite closely in neurodegenerative diseases. We did, or at least I did, hypothesize that this was that we would see impairments in executive function, although the rate was a little bit lower than expected, only about 15%, specifically 21% on trail making test part B. I think this could be a function of our test. I don't think we're really capturing some of these impulsive responding deficits in this sample. And then we also saw kind of scattered test performance across other tests and domains. This was published, this data, this past year, and we're happy to share the publication if interested. So that profile, though, is very similar to AD. So I want to walk you through a quick case example and show you the challenges, and to highlight the kind of the challenges of differentiating CTE versus AD. So this is a former National Football League wide receiver. He actually donated his brain to our brain bank. We collected his history through talking with the informants. This person had more than 15 years of football, he started playing at 14, 8 years in the NFL, or more than 8 years. He was a wide receiver, cornerback, kick returner. When we asked his family, they said they had more, about 500 concussions. And this was really after we provided a definition that any hit to the head results in symptoms of a concussion. In terms of clinical course, in his mid-60s, he retired as a construction and sales manager. He did start to have memory concerns and cognitive difficulties, but he was really functioning still quite well, in fact, publishing novels. His symptoms progressed, began to have some troubles with activities of daily living. He did go to have a clinical workup with a neurologist, neuropsychologist, and psychiatrist. And that workup did reveal kind of global impairment in all domains. If you look down here, this isn't a great image, but it kind of shows you the enlarged ventricles, some of the hippocampal atrophy and cortical atrophy that he was having. He was diagnosed with Alzheimer's disease. His symptoms progressed. He became fully demented. So he came to our brain bank, and as part of this workup, the clinicians take that history and come up with what we think is going on. And we also agreed that it's likely this is Alzheimer's disease. I mean, that's really a course you see very consistent with what you see in Alzheimer's disease. Given his exposure to repetitive head impacts, we thought, well, maybe CTE is playing a role as here, but overall, Alzheimer's disease was our conceptualization. After they did the brain workup, it was the severe form of CTE, stage 4 of 4, and really there was not much evidence at all of Alzheimer's disease in the brain. And so this really highlights some of the neuropsychology, and this is coming from a neuropsychologist, that neuropsychology can inform a lot, but it can only take us so far. So cases like this, it's going to be really, really difficult to differentiate CTE versus Alzheimer's disease without evidence of what's going on in the brain. And that's where the biomarkers come into play. Can we combine our neuropsychological tests with biomarkers of the brain in order to kind of differentiate CTE from AD and these other neurodegenerative diseases? And that's what we're focusing on now. So amyloid PET, this is kind of one of the most obvious roles that this tracer can play in CTE versus AD differential. So these have been tracers approved by the FDA since 2012. There's several of them. And ultimately what you can do is get an amyloid PET scan in someone like that individual and see if it's positive or negative. If it's negative, it can rule out Alzheimer's disease. But this is our gold standard for saying whether or not there's neuritic amyloid plaques in the brain. And that's one thing we're studying in CTE too, or people at risk for CTE, is the amyloid status of these individuals. Now, if we're trying to detect CTE, we're really trying to capture that tau protein that I showed you in the beginning of this talk or presentation. And we've started to look at various different tau tracers that have worked quite well in Alzheimer's disease and apply them to CTE. And ultimately, what we find is it's been challenging. We find kind of inconsistent results. We kind of find low binding in people at risk for CTE. We do see some effects, but it's not as strong as we were hoping, and we're kind of really not sure about how useful some of these tracers for Alzheimer's disease will be in the setting of CTE. So what do we know about the biomarker profiles of CTE? Right, the amyloid is going to rule in or out Alzheimer's disease, and the tau tracers are the data still somewhat inconclusive with small effects. But we do know, we have learned a lot about what the structural MRI profiles of CTE looked like, and perhaps most through this study that Dr. Mez and myself did. So what we did in this study is we took brain donors from our brain bank who had autopsy-confirmed CTE, and we had their MRI that was collected through medical record review, right? So we didn't prospectively follow these, but we had their MRI. And then we had neuroradiologists rate the MRIs for atrophy and for other types of MRI features. And so we did this for a group with CTE and then a group with people with normal cognition. And so here are some example images. So A and C is someone who had autopsy confirmed CTE, B and D is a control. And what we found is that those with CTE had more frontal lobe atrophy. They tended to have also more temporal lobe atrophy compared to the controls, as well as hippocampal atrophy. They were also 6.7 times more likely or higher odds for having a cavum septum pellucidum, or a tear in the tissue that separates the ventricles. Again, we don't think this is specific to CTE, but we do, and it can happen out in the general population, but we do think it's higher or occurs more commonly in people with repetitive head impacts. So those findings really highlighted, really highlighted some more frontal temporal atrophy in people with autopsy-confirmed CTE. Tau PET imaging, as I mentioned, we're still kind of exploring additional newer tracers, more novel tracers, one of them being called MK6240. There's some early data, particularly looking at tissue, that this tracer might help out, be useful in CTE. And this is a study we're doing with UCSF, where we've been getting MK624 PET, 240 PET on a group of former NFL players. In fact, this study is actually closed now to enrollment. We finished it, and we're currently analyzing the data and writing it up. Again, I think what we find is some kind of focal low intensity binding of this tracer in the medial temporal lobe. So you can see here in letter B, and also in the superior frontal cortex. Again, this is low intensity stuff. It's not kind of diffuse. The effects seem to be small, but we do see some signal that might help. So the conclusions is that I think if we can combine our neuropsychology to identify impairment, look at the patterns to inform etiology, combine that with biomarkers, that's going to give us our best chances of really getting a diagnosis right, including in CTE. And we've really gotten to the point where we're getting closer and closer to kind of clarifying what that neuropsychological pattern, rates of impairments, where the impairments are in CTE, and what are the structural MRI profiles of it. But I think, this is a little simplistic, but we still, as Dr. Mez will talk about, we're still in kind of that game of exclusion. Someone comes to us with a lot of exposure. We have to rule everything out. And if we rule everything out and still left, then we're really only left with one thing. It's kind of like, what else could it be? And particularly what's more challenging is these younger patients, as opposed to kind of the older patients who have kind of it looks like a full onset dementing process. But, but there's still kind of other questions, differences from AD, Alzheimer's disease, frontal temporal lobar degeneration. These are a lot of overlap in symptoms. AD, you can get a biomarker. We can easily rule that out. You can't as easily rule out FTLD with biomarkers because not great ones exist there. So you're really left with comparing syndromes. And so these are some of the challenges we're faced with. But now what I'm gonna do is turn it over to Dr. Mez, and he's gonna tell us how this all kind of translates to the care and the evaluation of patients.
All right. So thank you, Mike. Are you guys seeing my presentation mode or my actual? Okay, perfect. All right.
We are looking on the back end, Dr. Mez. If you could show the presentation mode, I believe. Oh,
Is that better?
perfect. Thank you.
Great. All right. So, Mike, that was a really nice presentation of where we are with the disease, particularly what we've learned about the syndrome, the biomarkers. And I'm really going to talk from here about what we are doing in our memory and aging clinic as it relates to CTE. And Mike and I work very closely in that clinic. It's a multidisciplinary clinic. It's very much framed in with the concept that this is CTE is a neurodegenerative disease, and we take a neurodegenerative dementia type framework. So I'll walk through what we typically do. A lot of what we do applies not just to CTE, but also to other neurodegenerative diseases that are in our differential diagnosis, including Alzheimer's disease, frontotemporal dementia, et cetera. And then I'll finish off with an example case. So a really important point for all dementing illnesses, all neurodegenerative diseases, that without looking at actual brain tissue, the diagnosis is never completely certain. And the current best workup is based on history, clinical examination, formal neuropsychological testing, blood tests, imaging, and/or a lumbar puncture. So the reason that these workups take so long, and the reason that there's these long wait lists across academic centers to get care, is because there aren't that many of us who do this, and the workup is long. And it's because it's not a single biomarker or a single piece of information that tells us what is going on. All right, so just as with almost everything in medicine, the history is incredibly important. So I'll spend several slides on that. We obtain the history both from the patient and an informant who regularly interacts with the patient. And this is really important because at least a subset of folks who are experiencing these types of symptoms have anosognosia, so they don't have good insight into their impairment. So getting collateral information from folks who are observing them is really valuable and crucial. Then what I will do is I'll start with a very open-ended question. So I'll ask something like, what cognitive, mood, behavior, and or motor problems are you most concerned about? And I'll just kind of let them speak. And what I'm really looking for is, when did the symptoms begin and how have they progressed over time? And this longitudinal piece is really crucial. And then after I've finished with those open-ended questions, then I'll hone in on individual components of cognition, mood and behavior, and motor symptoms. And that's what you see here. So I'll try to hit on all of these topics, at least briefly. So for memory, for instance, were they forgetting recent conversations? Were they misplacing objects? Do they require more lists? For language, are they having word finding trouble? Are they having trouble understanding what other people are saying? Attention, problem solving, executive function. So are they able to multitask as well as they could in the past? How well do they use technology compared to how they did in the past? visuospatial function. Are they still driving? How well are they driving? Are they getting lost? Have they gotten into car accidents? Activities of daily living. If they're still working, how is their function at work? Have there been reports of problems with their performance? If they're no longer working, why aren't they working? How are they managing cooking, keeping the house in order, taking their medications, things like that. We'll also focus a lot on this behavioral dysregulation piece, which Mike talked about before, because it is a core feature of the traumatic encephalopathy syndrome criteria. So we'll ask questions about impulsivity, short fuse, and when did that begin? How has that changed over time? We also get into details about depression, anxiety, paranoia, delusions, hallucinations. Visual hallucinations are particularly important for dementia with Lewy bodies. So getting that information, something that's in the differential diagnosis. Social disinhibition is particularly important for BV, behavioral variant frontotemporal dementia. And what we've tended to see is that, at least anecdotally, is that with frontotemporal dementia, we see this social disinhibition. Are they making comments that are inappropriate, or commenting on people's weight or appearance, versus are they angry and explosive, which is something we see more with CTE. We ask questions about motor, particularly Parkinsonism, as well, and then questions about sleep, REM sleep behavior disorder, obstructive sleep apnea. All right, and then we also spend a lot of time on the head injuries, and with a real focus on repetitive head impacts, because that's what we've seen has been associated with the CTE pathology. So we ask about contact sports, and we go into a lot of details here: the type of sport, the level of play, the years of play, the position. When we ask questions about military service, it's similar. It's really trying to get at the extent of the exposure to repetitive head impacts. So we'll ask questions like about their combat, their tours, their training, their operational deployment, their length of service, whether they've had blast exposures. We'll ask questions about physical violence and fights and intimate partner violence. And then we'll also ask about symptomatic concussions and moderate to severe traumatic brain injuries. And that's less because, at least from what we know thus far, is these are not related to CTE in the same way that these repetitive head impacts over years are associated. But we do know that moderate to severe traumatic brain injuries and concussions are associated with other neurodegenerative diseases, as well as just dementia more broadly. So understanding how that plays in is really valuable. A full social history, including substance use and alcohol, is very important here. I mentioned a bit about the occupation questions, marital status, living situation, education. These are all really crucial in the workup for dementia more broadly. We also take a really careful family history, because we know that neurodegenerative disease, dementia more broadly, has a strong genetic component. So we'll ask questions about each first-degree relative. Did they have cognitive impairment or dementia? When did their symptoms begin? The age that they passed away, whether an autopsy was performed. That autopsy question is often neglected, but it can provide really crucial information if it was performed. And then particularly when CTE is on the differential, we also ask about a history of family history of mental illness and substance use. So then moving on to the neurological exam. So I mentioned a cognitive screener here. I'm not going to talk about it very much. You heard a lot from Mike, but especially within the neurology setting, doing this screener is really valuable because it can give you some objective information and a signal that it's valuable to refer to neuropsychology. In our clinic, our multidisciplinary clinic, we automatically do the screener and we automatically do the full neuropsychological battery. I'll also do a neurological exam with a focus on Parkinsonism, so looking for bradykinesia, rigidity, resting tremor, shuffling gait. I also look for other things that can sometimes give hints as to what's going on. So I'll look carefully at eye movements with the thinking about progressive supranuclear palsy. I'll look for asymmetry in the motor exam, which could give information about Parkinson's disease, but could also give information about a stroke, a tumor, things like that. I also look pretty carefully for like axial rigidity versus rigidity of the limbs. Again, Parkinsonism. We see it versus PSP. And then, like Mike talked about, we consider the neuropsychological assessment to be a routine part of the workup. And he talked a lot about it, so I'm not going to go into this too much. But it is extremely important for getting an objective picture of whether there is cognitive impairment. So then we move on to imaging. A structural MRI is also something that we consider a routine part of our workup. It's FDA approved for the workup of Alzheimer's disease and other forms of dementia. It provides a lot of information. So it tells us about atrophy. So whether atrophy is present or absent above and beyond what we would expect for someone of the age that we're seeing. And then we also look at particular patterns of atrophy. Based on the paper Mike mentioned before, we may look for more frontotemporal atrophy, frontotemporal-parietal atrophy in CTE versus in Alzheimer's disease, we might see more of a temporoparietal pattern. We also will look for microvascular disease, which can explain impairment in cognition as well. We look for microhemorrhages, which can tell us information about cerebral amyloid angiopathy, which is associated with Alzheimer's disease. And then we can look for other causes of neurological deficits, like a tumor, for instance. And the biggest limitation of MRI is folks who are claustrophobic. They're in a small tube for 30 minutes or more, and contraindication is metal in the body. We will sometimes also consider an FDG PET scan. This is also FDA approved. It's only covered by Medicare if frontotemporal dementia is part of the differential diagnosis. It's safe. There's low-level radiation exposure. In this image, you can see a classic Alzheimer's pattern where you see decreased hypometabolism in the posterior part of the brain, the parietal lobes. We also, in certain settings, now pretty frequently, are looking for amyloid and tau as well. And you heard a bunch about biomarkers from Mike, but we have these really good biomarkers at this point for Alzheimer's disease that are FDA approved, including amyloid PET imaging. There's also some tau PET imaging that is FDA approved as well as evaluation of cerebrospinal fluid from a lumbar puncture. We don't do this uniformly, but if the setting is appropriate, we will do it. the disadvantages of the amyloid PET scan is that it's expensive and it's not covered by Medicare, but it is a very safe procedure. And then lumbar puncture, what's really nice about lumbar puncture is it gives us information about amyloid, tau, and neurodegeneration. We look at several different proteins in the cerebrospinal fluid, including a beta 42/40 ratio, total tau, and phosphorylated tau. It's also quite inexpensive relative to PET scanning. The obvious downside is that it's a more invasive procedure. That being said, the side effects of lumbar puncture, particularly when we use Sprott needles, which have greatly reduced the likelihood of developing a spinal headache. So once we've collected all of this data, we sit back down at a separate visit and have what we call an informing visit. And we, in a lot of detail, walk through everything that we learned during that first visit. So we'll rehash the history quickly, the neurological exam, the neuropsychological testing, the MRI. We'll also do blood work, which I didn't mention before, for reversible causes of impairment. So we'll look for things like thyroid and vitamin B12 routinely. And then we'll also review the lumbar puncture and/or PET scan, depending on what information we collected. And we then move on to talk about, based on all of this information, what the syndrome is, and Mike talked a bit about this, and I have a couple slides which I'll walk through quickly, as well as the etiology, and then we'll finish with the therapeutic plan. So first we talk about syndrome independent of the etiology, and we break it down into these three spaces of preclinical disease, mild cognitive impairment, and dementia. This figure is similar to what Mike showed with focusing. This is from Alzheimer's disease, but the same concepts apply across diseases, including for CTE. You can have individuals who have underlying pathology in their brain, but they don't yet have any symptoms, either on objective neuropsychological testing or involved with function and day-to-day activities. You can have individuals with mild cognitive impairment who have mild impairments on objective testing, but are still able to do all of their activities of daily living. And then you can have folks with dementia who have both impairment on cognitive testing and problems with their function. So then we move on to etiologies, so causes of the MCI and dementia. And we always look for these reversible causes because they are reversible. So that includes looking at replacing thyroid, vitamin B12 deficiency, clinical depression. It's really common that older folks are on an abundance of psychoactive medications, and that could be causing some of their symptoms. And then substance use in this population is not uncommon either. So then we consider different neurodegenerative diseases in our etiology as well. So Alzheimer's disease, vascular brain injury, frontotemporal lobar degeneration, dementia with Lewy bodies, CTE. What we've learned is that more often than not, it's not a single pathology. Oftentimes these pathologies co-occur. Ruling out or the finding of one pathology doesn't mean that you can't also have another pathology present. So then we finish with the therapeutic plan. Just like what Mike said, the general psychoeducation piece is incredibly important. And what we've seen in our clinic over the years is that just reviewing all of this information with patients and their families and kind of talking through what this is, what it isn't, just giving them clarification really goes a long way to helping them feel better. From a mood and behavior standpoint, we are pretty quick to refer to talk therapy, particularly cognitive and behavioral therapy. If the psychiatric picture is particularly complex, which it often is for these types of cases, we'll refer to geriatric psychiatry. For your more classic Alzheimer's disease or folks with more kind of run-of-the-mill depressive symptoms or apathy, as the neurologist, I'm very comfortable managing it with SSRIs. There's a pain piece that's often common with CTE because of their orthopedic issues as well, and so oftentimes duloxetine is valuable too. Quetiapine for agitation and sleep, I will prescribe on occasion. It has, of all of the antipsychotics, it has the fewest motor side effects. For cognition, we'll spend a lot of time talking about non-pharmacological behavioral changes, just changing settings when things that really drive problems or just not harping on some of the cognitive symptoms can make a big difference. If there's evidence of AD or DLB, we'll prescribe a cholinesterase inhibitor and memantine. We spend a lot of time reconciling medications that may be affecting cognition. So avoiding things like antihistamines and anticholinergics, avoiding benzodiazepines, avoiding large cocktails of psychoactive medications. And we'll send to the PCP for treatment of B12 or abnormal thyroid if that's abnormal. And then we also will focus on sleep, talk about good sleep hygiene. We may refer to it for a sleep study, emphasize the importance of using CPAP. Melatonin is good for resetting an individual's clock and is quite safe. I'm often hesitant to use clonazepam for REM sleep behavior disorder, but it's a risk-benefit thing. And we have used it in the past. And then, like I said, quetiapine if there's agitation. If there are motor symptoms, we'll refer to physical therapy. We also will work with our movement disorder colleagues. And then from a motor vehicle operation standpoint, we have a low threshold to recommend stopping driving. We'll often also recommend a driving evaluation. And then we emphasize healthy lifestyle. So what's good for the heart is good for the brain is something I think I say in almost every clinic visit. So we talk about American Heart Association recommendations of moderate intensity aerobic exercise for 150 minutes per week, or at least 75 minutes of vigorous aerobic activity. We talk about a Mediterranean diet, a heart healthy diet, and then social and intellectual engagement, going to museums, interacting with friends and family, having engaging conversations has been shown to be beneficial for good cognitive aging. In terms of safety at home, we'll refer to elder services or PTOT as needed. The Alzheimer's Association and the CLF websites are incredibly valuable, and we really plug both of them. And then care for the caregiver is incredibly important as well. So things like support groups and respite are really important. If caregivers aren't in a position to provide care, then both the caregiver and the person with the disease suffer. And then we also talk about advanced care planning. All right, so I think given the time, and you heard a example case from Mike, I'm going to skip this last case and give you all a bit more time for questions. But I do just want to finish with some closing remarks. So just to emphasize, we use a neurodegenerative framework rather than a persistent post-concussion symptom framework. We really look at CTE as a neurodegenerative disease, and the workup mimics what we do in the setting of other neurodegenerative diseases as well. And then the current best workup is based on history, clinical exam, formal neuropsychological testing, blood tests, imaging, or lumbar puncture. And it's really no single piece of information is sufficient to make a diagnosis. And then I think what we've really learned, one of the things we've learned the most from this clinic is that psychoeducation goes a really long way and can be incredibly effective. And although we don't have disease-modifying therapies for CTE, there are many effective non-pharmacologic and pharmacologic symptomatic treatments that I outlined. And then in the academic space, leveraging research infrastructure to concurrently provide clinical care and conduct clinical research provides this mutually beneficial opportunity for patients and for investigators. So our clinic is really closely tied with our research, and most of our patients are also participating in research. And that gives them a wealth of opportunity, both to inform what's going on with them, as well as to be part of groundbreaking new research. All right, so I think with that, I will stop and we will take questions. And a plug for our clinic here.
Thank you very much, Drs. Mez and Dr. Alosco. We very much appreciate your time, and we do still have some time for questions. I see many of the participants have stayed on. We have a few great questions that were sent by chat and direct messages, but if you would like your question to be answered, please do drop them in the chat or in the Q&A. Just to get started on a few that have come in. First, and I will pose these questions and wait for Dr. Mez or Dr. Alosco to volunteer to answer. But first, we have a question asking, are there any treatment speculations when CTE suspected, perhaps adding on the previous slides, or anything you would like to comment on?
Sure. So, I mean, I think that I walked through what we have right now. I think importantly, that was a long list, and I went through it pretty quickly. But you know, we'll often spend a full hour on that informing visit, walking through all of the diagnostic information and the therapeutic information. We often can't even get to all of it in that time. I will say that in order to identify therapies, you have to be able to diagnose the disease in life. So a lot of the focus right now is on diagnosis, and that's what you heard from Mike during his talk, and that's what a lot of our research is on. Once we have a diagnosis, then we have a landmark where we can look for therapies, whether they're disease modifying or symptomatic treatments.
Thank you, Dr. Mez. Another question we received this time about CTE presentation. Are there different types or groupings of CTE? And a connected question, are there differences in clinical presentations versus pathology that may be relevant?
I can start. So I think there's kind of two questions there. One, are there different subtypes of disease or pathology? And then two, is there different presentations which are probably related or are related? So I think, yes, I think some of this data is currently being worked out and prepared, but we do see different types of disease in the brain. For example, there's some where we see cortical sparing of the disease, and meaning, and there's more medial temporal lobe involvement versus the cortex. We also see a lot of differences in kind of the overall density of burden in the brain. So I think we are increasingly seeing different diseases, different disease types in the brain. Clinically, I think that's something we're trying to figure out. I mentioned, like in Alzheimer's disease, there's a good proportion who present with a non-amnestic syndrome. So the more we learn about neurodegenerative diseases, the more we learn that they have atypical presentations, and the more we learn that they co-occur, making things even harder. And this is probably going to even be more problematic in CTE, because we see that repetitive head impacts might actually influence the development or risk for a number of different neurodegenerative diseases, and that it can all affect clinical presentation. So I think in summary, the presentation can be pretty heterogeneous.
Thank you, Dr. Alosco. Moving on to another question. Have you encountered patients with a recent brain injury as well as possible neurodegeneration? If so, how do you differentiate between symptoms and severity, or how do you approach?
I guess I can do this one.
Let's take turns.
Right. So, yeah, so kind of like I mentioned, there's this accumulating data that single traumatic brain injury, particularly moderate to severe, is also associated with dementia and neurodegenerative outcomes. And you can have both of those together. You can also have a recent TBI that is causing symptoms, and that can be overlaid on a neurodegenerative process. We touched on the fact that neurodegenerative diseases in the Alzheimer's space, and we've also shown in CTE, start many years before symptoms may manifest. So it's really hard to get at what's the chicken and what's the egg when the disease might still be silent. What we see in dementia more broadly is that somebody might have the underlying pathology, might have good resilience, might not be showing any symptoms, and then they take a hit, whether it's a traumatic brain injury, a stroke, get hospitalized for something systemic like sepsis, and then they can no longer compensate, and they start to decline and manifest their symptoms from their neurodegenerative disease. So it's really hard to disentangle those two pieces, but I think it's getting at the timeline and the temporal relationship that really kind of sheds light on what the etiology might be.
Thank you, Dr. Mez. Next question, and we have a few more. I'm being mindful of time. How do you respond to patients who are very fixated on what stage of disease they're currently living with?
Yeah, it's so we get, this is where the education comes in a lot, because there's so much information everywhere out there. And it's not uncommon. That question is very fitting, because it's not uncommon where people will come in and say, I have stage XX, CT or whatever. And it's just, it just comes down to kind of bringing it back to, listen, we're here to identify, is there a progressive brain disease? We can answer that question pretty confidently. We're not yet confident on whether or not CTE is even present, but even if it is present, we can't do much about it at the time. So let's think about the symptoms. Let's focus on what's going on. What can we do to help you? What can we do to treat these symptoms that you have? And a lot of times these individuals have a lot of symptoms that can be treated and receive benefit. Sleep apnea, depression, right? Regardless of the cause, we know how to treat depression. Sometimes it's hard to treat, but we know how to do it. So I think, those are types of questions where you spend a lot of time educating the person about what we know about CT, what are limitations, and so on. Even going back to the TBI piece that Dr. Mez answered, that's another thing we commonly get. Someone comes in with 1 or 2 TBIs and say, hey, I think I have CT. And again, it's kind of like, this is what the risk factors for CT. We don't think you're going to develop CT if you just have 1 or 2 TBIs.
Thank you, Dr. Alosco, for answering a tough question and good question. I think we'll go one more potentially, and this question I think is about the wider care team. What providers would be included in the ideal clinical care team for someone with suspected CTE, or perhaps what other wider providers are on the memory and aging team?
Yeah, no, that's a good question. So I mentioned neurology and neuropsychology, or behavioral neurology and neuropsychology. We also work closely with a geriatric psychiatrist. We also have worked not uncommonly with a movement disorders neurologist. I think with all kind of dementia clinics, having social work is particularly valuable. We work with our Eric Steinberg, who is a nurse, longstanding nurse practitioner with our study, who has also done a lot in terms of care providing, kind of social work related issues. So he is an important resource for us. We don't include something more like having a kind of a geriatric care manager, somebody who can really kind of help people navigate the landscape. So if it's things like getting services in the home or finding a better place to live, I think that would be really valuable in the ideal setting. It's not easy to have resources for that. I think another piece that's unique to our clinic, which I find really valuable, is that so we have individuals coming to us from all over the country to get care, and then we serve in that setting as a kind of like a consultation service. But then they need to go back to their home and get more care. And we don't necessarily know physicians or know neuropsychologists or whomever we're looking for in that setting. And we work really closely with CLF, who has this really good network. And that's a really nice resource. So I'm sure I missed things, but I think the care team is incredibly important, and it's a good question.
Thank you, Dr. Mez. And once more, I want to thank you both so much for your time, and thank you to the attendees for your time and your excellent questions. We appreciate you joining. We do have additional CMEs that will be coming up through the fall. Please do look to the CLF website for information about those upcoming events. Please also look for a follow-up email tomorrow with the presentation deck, with the content summary, and with the instructions to claim credit. Thank you again, and I hope you all have an excellent rest of your day.
Thanks, everyone.
Thank you. Take care.